Okay, so now that we are on the record, I'm going to do a very poor impersonation of DJ3. We had him scheduled for this back on the original date, and he is out on leave this week, which is good. We all need to be able to take that time. But wanted to welcome everybody to our Cultural Humility Workshop. And I would like to pass it over to Yoli from Neighbor Care to give us our official welcome. Yoli, the floor is yours.
Great, thank you, Ryan. Hello, everyone. I'm Yoli Grandjean. My pronouns are she, her, and I'm the Clinical Education Program Manager at Neighbor Care Health. And I wanted to talk a little bit about why this work is important to us, specifically at Neighbor Care, but probably all of us who are on this call since we're here. And to say thank you so much for being here to participate in it, because for us at Neighbor Care, it's near and dear to our hearts. We operate by a set of service commitments, which essentially are principles that guide the work that we do every day. And two of our service commitments really stood out to me in the context of this work, and they are trusting relationships and respect. It's really important to us, and we value at Neighbor Care building trusting relationships with patients and with each other, and cultivating ways to show respect. And so I thought I might just read a little bit about our respect service commitment to set the stage for today. At Neighbor Care, we honor the beauty of what we have in common and the richness of our differences. We see each person as unique, and we strive to meet their individual needs. In this space, each can count on being recognized and appreciated for who they are and who they can be. We value differences in perspective, personality, and experience. We are excited and curious to learn about others with the humility to try and see through another's lens of the world. So again, I want to say thank you, because I think this work is really going to help us as an organization lean into that service commitment and to be able to provide care with respect every day.
All right. Fantastic. And then just to just a quick refresh on our HILT purpose and vision. So HILT is a network. So James, Shalane, and I are your co-conveners, or the cat herders, we like to say. But HILT is that network of health providers, and we all come together to be able to take action. And today's gathering here around the cultural humility scenarios is an action meeting, because I think we're all going to walk away with tools to be able to advance our work. And just a reminder, it is HILT's birthday month. So HILT has turned 4 years old this month, so we'll be celebrating that a little bit later, and hope everybody can join the full HILT meeting at the end of May. And then to kind of tee us up a little bit here about why this and why now and why we got here, I did want to call on Mardia, assuming that Mardia has finished her slides for her scenario. I know we were putting, would you like to share a little bit from the perspective of Swedish Health Services about why this, why now, and how we got here today?
Absolutely. James, you're driving? Okay, next slide, please. Okay. No, I think my slides are kind of, yes. So here we are. So here's the plan, and let's talk a little bit about why are we here today, and just a little bit to refresh why this, why now, and how did we get here. We had some conversation around cultural competence and cultural humilities, particularly as it relates to healthcare, obviously, being in this space. And one of the things that we wanted to talk about is really how do we approach this work when we look at who is coming into the healthcare space, and whether or not people are equipped to be able to work with the diversity of patients that come into the healthcare space. Predominantly because, and you know, we're what, 2 years, going on 2.5 years into the COVID crisis. And one of the things that we all know that it exposed was the disparity in healthcare, particularly for BIPOC folks. And with regard to that, we know that the reality is these disparities have existed for a number of years, for decades and decades, because of just the social determinants of health. And I'm using terms that I think we all are familiar with regard to housing and food security and transportation and childcare and things of that nature. And subsequently, with the advent of COVID, it really laid bare the fact that there are just racial inequities across the spectrum for BIPOC folks. And when we enter the healthcare space, it really truly does lay bare to the fact that these inequities and these disparities exist. And subsequently, when folks of color enter the healthcare space, as consumers of the services that healthcare provides, oftentimes caregivers, providers, clinicians, APCs, physicians, you name them, aren't necessarily equipped to work with folks who are of different ethnicity, different race, different sexual orientation, gender identity, and so forth. And because of that, we started to have conversation about how do we prepare a future workforce for the reality of the not even the future, but the here and now of what the diversity of the patient population looks like. And how do we, as folks who are in workforce development, how do we extend that even into we could say colleges and university, we could say technical education, we could talk about, that level of training and expertise. But the reality of it, I was having a conversation and I was talking to somebody and I said, we could theoretically start in the 6th grade, the 5th grade. And they were like, honestly, you need to start this at the 3rd grade. I was talking to somebody in education. And, and I asked them why. They were like, well, the reality of it is kids get interested in things around math and science, and math in particular. Kids are afraid of math as early as in the 3rd grade. And which stunned me, because as I started to go back in my own educational pursuits, I got afraid of math in 3rd grade when I had to stand in front of the class and recite my times table. And that threw me off of math for until I had to graduate from college, and they were like, yeah, your last semester, you're not getting a degree until you go through calculus. And I say all of that to say is that we need to cultivate a generation of students who are not afraid, and a generation that includes BIPOC students who are not afraid to go into the sciences, because we need BIPOC providers to come into healthcare in order to meet the demand for diverse patients that come into the healthcare system, because that's the only way that we're going to see true health equity, because we're going to have cultural humility and cultural competence in the healthcare workforce space, which will lead to better health outcomes, not only for BIPOC patients, but for all patients. Because we know that diversity breeds diversity, diversity breeds an understanding of all of the idiosyncrasies that come with the variety of people that enter our spaces. And as we started to talk about this in terms of what the future of the healthcare workforce looks like, we started with education, and we started with making sure that the educators within HILT understand that we need to educate a workforce and get our workforce ready in a way that recognizes the entire person as they come into the healthcare space, because that's what's creating health inequities and health disparities. And so to tee this up, this is what is happening in the industry right now, why we're seeing these huge disparities, why these disparities continue to persist, because our workforce has not yet kept up with the demand that the patient population has created in terms of you need to know me as an entire individual that comes in your door with all of my life situation and circumstances, and you need to know me in order to be able to better treat me in a way that honors who I am in my full humanity. So this is how the conversation started and how we need to focus on educating this workforce that is going to eventually be the workforce that we need in order to run these successful healthcare organizations. And so as a refresher, this is kind of why we're here, why now, why this is such an imperative, and why we need to really look at this from a DEI perspective and look through an equity lens at this work. And so with that, I will ask Liz to talk a little bit about the education perspective.
And Liz needs to turn on her microphone. Thanks, Mardia. And I did have a chance to talk with some of our faculty and a couple of my colleagues, but obviously I didn't have a chance to get everyone. So, but I think from an education perspective, we really want to explore how we can best prepare our students to be those holistic care providers. And sometimes from an education perspective, it's difficult because there are standards and there are skills and there are competencies, and it's trying to fit it all in. It can be difficult, but we continue to look at that and provide that. But I think in the conversations that I've been involved in with this is, I think, an understanding where those gaps exist as our students leave our campus and enter their professions. And I think the connection here is it breaks down that silo that says, you know, we're both working on this, but we need to understand each other's perspectives a little bit better. And from the education perspective, we really need to know where those gaps are. We also want to provide opportunities for students to explore their own worldviews. And how that impacts interactions with clients, with patients, and provide a safe space for them to practice and build these skills, because it's difficult. We want to give examples of how different cultural groups approach issues of health and how that impacts interactions and outcomes. And culture, the word culture or cultural groups expands over time. One of the things that, you know, is really has a focus right now that I hear from Mardia and from Yoli, the issues of gender. And that's something that we're starting to explore within education. And then really infuse those cultural considerations into all of our simulations. You know, the pandemic, we've really started to use simulation to replace clinical experiences. And so we need to come back to that holistic and make sure that we're dealing with the cultural considerations. And so for industry to help us, what are those scenarios that demonstrate that breadth of cultures that we're going to encounter? And I'll give you an example of something that we just started on here. James, if you can go to the next slide. We were looking at, we have a mental health technician program that incorporates nursing assistant plus the mental health technician. And we were trying to do a sort of a cross mental health, physical health scenario. And when one of my faculty came to me with this, and I was reading through it, and I'm looking at a 20-year-old woman with a 3-month-old baby. She's an immigrant. She's with her husband. Her mother-in-law is not exactly favorable towards her, thinks she's lazy. There's a lot of information there that informs there may be some cultural issues. There's certainly family dynamic issues. The skill is, the assessment is vital signs and pain assessment. That's kind of the competency skill. But then this person also added interpersonal communication. And I said, let's see if we can flesh that out from the cultural perspective, because you've provided a lot of information that's going to affect communication. And then we also added is what then needs to be communicated to the RN or the physician, the next person in line. What are the observations? So how do those healthcare providers interact and pass information along as well? And then lastly, from our perspective, and one more slide, James, is looking at going forward. What we'd really like to start looking at is expanding to diagnostic areas, such as the imaging area, the medical lab, particularly phlebotomy, where there's touch, there's issues of dress that need to be worked out with. And then with COVID-19, looking at the pharmacy, it's a lot of different environments, there's community clinics, but we can also look at issues that have come up related to COVID-19, particularly vaccinations. I think there's an opportunity to look at what are some of the cultural implications around that. And then looking at all staff levels to build awareness early in their educational journey. And Mardia, you talked about starting in the 3rd grade. And I'm thinking about starting at the nursing assistant level, the dietary aid level, the front office person level. And these are folks that are going to continue their educational journey. They're going to continue their career journey. If we can get to them early and give them a solid foundation, and then we build on it, and then, but keep reminding them that the learning continues. It never ends. And lastly is to see if we can find a way to really create something interactive that we might be able to do virtually. And that might involve technology. It might involve looking at some open educational resources, but scenarios that would show both positive and negative outcomes during an encounter with a client, and a good demonstration of how do you turn a negative into a positive? How do you recognize when, okay, this isn't going so well? And how do I turn it around? How do I recognize what's going on, and how do I turn it around? I could probably go on for hours about that, but I think in the context of this space, those are some pretty key things that we'd like to focus on.
Great, thank you, Liz. That is really insightful, and we definitely appreciate that perspective and many things to consider. We know that Mardia is going to be coming back on. She has some additional slides to share and was going to expand on some of these ideas as well. When she's getting prepared for that, we definitely appreciate everyone's input and dialogue in this. Mardia, over to you.
Okay, got another slide coming up, I think, after this one. Let's see, there we go. So one of the things that I talked about was with regard to cultural humility. And what's interesting, so there are 2 terms that we go back and forth with, and sometimes we use them interchangeably, and it's incorrect. So we talk about cultural competence a lot. And in this case, I really wanted to talk about cultural humility. Competence suggests that you've reached the end of the line, and at some end point, you are a master, if you will, at whatever skill that you are attempting to master and to know. Humility suggests that you're on an ongoing journey of learning and so forth. And I think DJ3 put in there learning in the chat. Learning is key. And so I wanted to talk about cultural humility in particular and how it plays into healthcare. And so I put some definitions up here, and then we'll get a little deeper into this part of the conversation. And by all means, please put your questions and comments and so forth in the chat, because I'm kind of looking at that as well too. So cultural humility is really about, taking a look. It's about being respectful and being humble enough to recognize and to understand that you need to challenge your own self. You need to challenge what are your own biases, and do some self-reflection. And it's a lot about introspection, and then recognizing and realizing that you are on a journey, and that you are just, as human beings, I am never going to know all that there is about any one person, any one culture, any one individual, that this is a relationship that you enter into with people and a person so that you can learn what you can about them. And it really becomes personal, especially as it relates to healthcare. And in recognizing that and walking into situations with a questioning attitude and wanting to learn more is really about how you enter spaces with people whenever you're in situations in which you are unfamiliar, and even in situations where you are familiar. Cultural humility really helps guide the best way to interact with folks. And so I really wanted to put this in here as we look at how we go about doing this work in the most effective way. And it's about creating deeper connections with people and having this understanding between patients and providers, because ultimately it increases patient satisfaction. And people know, we all know when somebody takes a personal interest in us and in our care, and it could be in a healthcare setting, it could be in a business setting, it could be in an education setting. We as human beings know when somebody takes a personal interest in us, or when they are working with us on a cursory basis and they want us to hurry up and get out of their office or move on to something else. And so when you create that deeper connection, it just really helps you understand a little bit more about the person and how you can provide care in a way that honors the person in their full humanity. And when we look at it from the standpoint of who are our patients, who are the people with whom we are interacting, that is the level of concern and care that we need to bring into these spaces. And the complexity of the identities of folks. People come to us from all stations of life. And as a DEI professional, I will bring up a dimension of diversity sometimes that people haven't even considered. And I will say things like, have you considered that they may be an only child? And that is a real thing. The only child syndrome, only child, you didn't have to share your toys. And, so some people enter meetings and, they are used to being the center of attention, and they will take over the entire meeting and talk because at the dinner table, they were the only child. They got all the attention. And so they behave that way. So that dimension of diversity has to be taken into consideration when you deal with them. And so, I bring all of those things to bear when we work with individuals. And so I just wanted to bring up that very simple example as a dimension of diversity, in addition to your sexual orientation and your gender identity, in addition to your race and your ethnicity, in addition to your social economic status and so forth. But just understanding the complexities of the identities, that even in sameness, as a Black person, I was not an only child, as a middle child. And so, that has stories around it in and of itself. And so again, cultural humility, you're on the spectrum of lifelong learning as the goal and as the process. Next slide, please. Why is it important? It is important, particularly in healthcare, because it plays a crucial role in delivering quality care. Some of the things I'm going to tell you as a person who works in healthcare, a bad word, a curse word for me is non-compliant. Non-compliant patient. I'm like, what in the world does that mean? And so here are some things that we look at. We talk about equity-focused language. Non-adherence as opposed to non-compliant. Why are they not adhering to whatever the care plan that we've put together as opposed to non-compliant? So trying to get folks to use equity-focused language and placing the blame for treatment on whatever circumstances is happening in the person's life as opposed to putting it on the person. They did not adhere to the care plan in terms of coming to their follow-up appointment because they didn't have reliable transportation. Not that they were non-compliant and they didn't show up to their doctor's appointment, well, because they didn't have reliable transportation. And so taking the blame off of the patient and putting it where it belongs on the circumstances of the person's life. These are people that we're talking about. So again, using the right equity-focused language and words and so forth. Similarly, this is again, being humble enough to recognize people's situations and their circumstances, the ability to remain open to other people's identity, their cultural background, beliefs, values, and traditions, and so forth. And then learning what is important to the patient, and then leaving every encounter having learned something. What did I learn from this person in the encounter? And again, this all goes back to continuous learning about people and about what their identities, what is their circumstance, who are they as a person, who are they in their full humanity. That's why it's important in healthcare, because this is how we're able to deliver equitable care to people. If we look at people as individuals, as opposed to just a group and just a mass, as opposed to this individual person needs my help, and I need to learn a way in how to get to them, get through to them, and get them to understand what it is that I'm trying to convey to them in order to deliver that equitable care. So this is what we want to focus on when we talk about cultural humility, and how, again, we want to extend this into the education that we are providing to those who are moving into the healthcare space as providers. And that is, that's what I wanted to share with you with regard to cultural humility, what it is and why it is important, and why we need to put this in the context of educating those who are moving into this space. Again, thank you.
Great, thank you, Mardia. That was very well said, and lots of different aspects to understand when we're dealing with patient care, and understanding that, you know, making assumptions is not the way to go forward, especially in a medical environment where you're using factual information. So we had a lot of good comments in the chat, and thank you, Denise, for your points as well. So yeah, I think that's really important. We're going to be moving on a little bit to do some sample scenarios. We've got scenario 1. Yoli is going to be doing scenario 1. And then we have another scenario produced by Denise, and she'll be sharing in scenario 2. Yoli, I'm going to let you go ahead and take it away, and we're going to go right to your scenario, and you can describe that and lead us along into the education.
Great, thank you. I just want to give a shout out for scenario-based learning and how important it is, not only for healthcare professional students, but for healthcare providers and people who are already on the job, to give them a way to make mistakes in a safe environment, to try things in a scenario and to see what works and what doesn't work. And so as we're going through these scenarios, I would encourage you all to be thinking about how we can use and even optimize these kinds of scenarios to create those learning experiences around cultural humility. And DJ3, I saw your comment about, you know, really focusing on the learning aspect so that it is an ongoing part of our development as professionals and as people. So that's kind of how I want to frame this, is how do we make these scenarios into great learning experiences for our people, whether those people are students or healthcare workers or somewhere else on that spectrum. So I will not read this slide to you. I'll try to kind of set the stage for the scenario broadly. It crosses a couple different settings, and this scenario came to me from one of our nurses working at Neighbor Care from her own experience. So the settings this includes is both inpatient and outpatient in a primary care provider's office. The providers in both cases were white male medical doctors, MDs. The patient is an African-American male who we'll call Fred, and has a history of substance use. When he was admitted to the hospital for a stroke, he was diagnosed with right-sided heart failure. It was a new diagnosis for him. So in this scenario, we have another player, and that's the nurse advocate. So I'm going to skip down to the dialogue just to get a sense of where we might pick up with this scenario. And the first set of dialogue, which is really brief on your screen, is in the inpatient setting, where as the patient is being discharged, the nurse advocate says, can we get a referral to a specialist so we can learn how to manage the heart failure? The hospital clinician replies, no, you need to go to the primary care provider and get a referral from them. So that's kind of sub-scenario, maybe number one. And then we pick it up at the PCP office, maybe several days later, where the nurse advocate goes with the patient. They get a referral to pulmonology, and the PCP expresses that they want to take the patient off of Lasix, which was a new prescription from their hospital admission. The PCP says his blood pressure is fine, he doesn't have any swelling, he doesn't need the Lasix. Within 3 days of that visit, the patient developed shortness of breath and needed to restart the Lasix, which resolved the shortness of breath. So thinking about those two kind of sub-scenarios with the same patient, we have some questions on the left side of this slide to consider from a learning perspective. So as a learner, we could talk about what is the patient outcome that we're going for in either or both of these scenarios? What assumptions do you see being made? And I would add potentially bias as a factor there. Oh yes, what other factors may be at play? There we go. And 2 alternative approaches or actions that could have been taken. So maybe we can start by opening it up to talk about some of those questions. I'll also keep an eye on the chat in case people don't feel like unmuting.
I'll jump in. The first thing I see is lack of an attempt of continuity of care at the point where they're being discharged. It might not, and I'm no clinician, but the process of simply citing that their GP is the person that should own the responsibility of that referral seems kind of callous in that situation. So I think there could have been more of an attempt to for an easier handoff for that process.
Absolutely. We see maybe a missed opportunity for continuity of care. Thank you, David.
One thing that I thought was missing is that no one really asked the patient what he wanted or what he needed.
Right, lots of assumptions about what needs to happen next and what's best for the patient, but no clear indication that the patient communicated about that.
You know, as someone who's had a chronic knee problem for a number of years, you learn about your condition, and just to be excluded from the conversation in that moment where care decisions are being made for you and about you, and no one's asking the person who's having the experience, who may have valuable information to contribute. And it can be a bit of a pain to tell you, oh, you got to go back to your primary care person to go see. So let me get this straight. I got to leave a heart doctor to go back to a primary care physician to get referred back to a heart doctor. It just begins to be insurmountable. And if you're challenged with low income or job issues, that time may keep you from seeking out the care you need.
Absolutely. And I want to call out a couple. I love, Mardia, your term dimensions of diversity that I heard in that response, which are job, socioeconomic status, those kinds of factors that play a role here as well. Mardia, it looks like you were going to add something.
Yeah, I was, and DJ3, thank you so much for that comment. I encountered a patient within the last few months or so who was deemed non-compliant because he refused all treatments that was made without his consent and was then brought to him and he was asked to then comply with. And then the patient was subsequently called non-compliant. And I just, so when I got called in to talk to the patient and get him to follow the orders and so forth, what he said to me was, they're out here making decisions left and right. Nobody's involved me in any of this conversation. And they just want me to take this medicine, do this procedure, do this. And no one has even bothered to ask me anything about it. And so when they come in here and say, take this medication or do this test and do this, I'm saying, no, I'm not doing that. Nobody bothered to say anything to me. And I just was like, so very simply, all of this could have been avoided if y'all had just had a conversation with the patient and explained to him, here's what we're thinking about doing to care for you. And, here's what this medication is going to do. And here's what we think, and so forth and so on. And this went on for a week. And when the patient finally was at the point where it was so bad, they were like, Marty, can you come in and talk to the patient? And I was like, yeah, sure. And then when I asked him, that's what it was. He would not adhere to anything that they wanted to do because no one bothered to talk to him and ask him about any of the course of treatment. And to your point about having been in the healthcare system and having, had this condition, he had been in multiple healthcare settings. He knew his condition better than any other physicians in there. He knew what dosages for his treatment and all that, and nobody bothered to talk to him. And then he got labeled non-compliant. And I just was like, which is why that word is a bad word for me today. Just talk to people and explain to them. Do not make assumptions that they don't know. So when I look at this scenario on here too, yeah, who asked the patient? Where is the closest specialist to you? Is there, can you get to this specialist? Is there somebody who you might even be interested in going to? One of the things that they're talking about specifically on here, this sentence just says, can we get a referral to a specialist so we can learn how to manage the heart failure? To whom are you referring the heart failure? This is a person. So we can, it's one of the things about healthcare that we talk about too is we focus on the disease and not the person. Is something else that we do as well too. The disease becomes the person, and people resent the fact that their condition becomes the identifier for them. So I just have a problem with this first statement coming out the gate.
I would add to what Martys is saying. We're saying so we can learn how to manage the heart failure. Who's the we?
Yeah.
Is it the patient? Is it the nurse? Is it the doctor? Because I'm also not seeing and I think Monica made a reference to it in the chat, talking about environmental factors. What is his home situation? I mean, we're discharging this patient home, and is there the capability at home to manage the heart failure? Or are there circumstances at home that might contribute to what they're going to feel is non-compliance?
I have a question about that, and it's sort of stepping back a little bit from being in the scenario as a learner and thinking about how we write these scenarios and what kinds of information we include. And is it important to include that level of detail in these scenarios so that learners can focus on the cultural humility piece? Or is it okay to leave some of those things unsaid and encourage learners to think about, well, what am I missing here? What other information would I need in order to provide the best possible care for this patient?
I'm kind of thinking you might be able to come at it in both directions, because I'm thinking, you have enough information there that, all of the things that have been raised about the cultural humility, but then I would want my students to be thinking about what's missing, what don't I know? And right now, what I don't know is what the patient's home situation is, or to Martys' point, if they're going to go to a PCP, what's their transportation? And I would almost like to have them or help guide them to be asking those questions as opposed to giving them the information all the time.
This is Carrie Miller from Seattle University, and I run the SIM lab here at College of Nursing. And I have to say, I agree with Liz. There is aspects of simulations that we really want there to be a point of discovery. But there's also components of simulations that we want to be set. So students have the guidance that they need, but we really do want them to discover. And many of those points of discovery come out in the debriefing sessions, and that's where the learning is so rich. And this is a great scenario, but there's tremendous opportunity for them to discover and to be able to be aware of their own biases and judgments, and then to be able to bring that forward in a safe, open, non-judgmental learning space to be able to explore that. And so, yeah, this is good.
I think Monica is echoing that in the chat. Let the learners come with this discovery as part of the process.
Yeah, this is Monica. I totally agree with what you're saying, Carrie. I think a big piece of this, what we don't necessarily teach explicitly very often, is how we uncover what the gaps are, which I think is what we're really trying to do here. How do we teach the critical thinking required to investigate and turn over the rocks? I think so often what we're doing is we're focusing on process and, you know, here's some role play, here's a lot of structure, and we get so bogged down with structure and compliance and those types of things that we forget our humanity and don't spend the time, which is another problem issue with this whole business of healthcare, is we're trying to get to the root of the problem, or what we're here, you know, what is the task I need to focus on? And we end up shorting the conversation and that quality by focusing on the structure, because we rely on the structure to provide efficiency, which is really counter to what we're trying to do.
Yeah, and one of the things that I still practice as a registered nurse, and as well as being an academic, is that I'm constantly saying to learners, you know, the client, the family is the center of the circle, not the facility, not the disease, the person. And there is intentional pause in that statement that we, and I learned this actually when I was at over in Bremerton working in Silver. God, I used to live there and I just went blank. Silverdale. And the ORs, because I worked in the OR, and the ORs had a circle in the middle of the room, and the OR bed was in the circle. And so you had that constant reminder of what is your priority? Who is your priority? And it really was profound. Yeah. So thank you for letting me share.
Something else I'm hearing in your comments, Carrie and Monica, is the importance of the facilitator role in going through these scenarios with learners, whether they're students or healthcare workers. And as we talk about potentially building a library, a robust library of scenarios for learning, do we need to also consider how we are equipping facilitators to walk with learners through this work?
I think that's a good point, Yoli, to what Carrie and Monica are saying is we want to be able to provide opportunities for discovery, but then how do you get them to that point of discovery? So it's also, how do we engage the students in the work? And, you know, I do scenarios and, you know, students will say, well, I don't have enough information. And I said, well, let's kind of back up on that. And let's take a look at what we do have. And then you tell me what additional information you want and why. What difference is it going to make? Rather than just saying, I don't have enough information. And so it's, yeah, how you walk them through it is important.
I think it might also be building confidence in people doing this work to embrace the idea that they are not going to have the right answer. So this kind of ties in with everything that everyone is saying around always learning, always being curious, all of that sort of thing. And so often we're just wanting to get to the right answer. Like, I need to know that it's right. I need to know that I'm right. I need to, you know, answer a specific question, where it's okay to accept like, okay, we're going to work in a gray area here, right? And we're going to continue to build this relationship and so forth over time. And when I leave here, I may still be working on this, and I might come to some sort of great insight after all of the chaos around me settles. So creating that place where it's okay to not have a specific answer or a specific nugget in this very finite amount of time that we have, I think is also important. So it's not only nurturing the curiosity, but the courage and the confidence to sit with things for a while and to continue to be on that journey, as Marty was saying.
Yeah. And Monica, the only thing I would add is it's okay to be restless. It's really okay to walk away and from a learning and be a little restless and go, wait a minute, what was missing? Why?
I think that's great. Yeah.
Yeah.
Shauna, I think you had a great comment in the chat kind of along the same lines, and I was wondering if you wanted to elaborate on that at all.
Yeah, I mean, I think my thinking there was just that as I was thinking about my own experience as a learner with scenarios, is that it can be easy if you're in an academic environment to get caught in that place where you're trying to find the right answer. And that often if scenarios are well facilitated, they do allow you that space to just like really lean into your, where you might have blind spots or things that you're feeling curious about, places where, imagining that there are types of questions that might add value to the interaction that the provider or one of the providers in this case was having with the patient that might have enhanced the experience and created not just better outcomes, but a better care experience for patients. And that if that's well facilitated, often a lot of the learning comes from just the reflection that you do as you exchange with others, right? As you and people think of questions that you might not have occurred to you, right? And that there's space for that reflection on, oh, that that's an interesting angle. And I think so much learning happens in that space where you just are, open yourself up to the fact that there is a lot that you don't know and that there aren't always necessarily right answers, but that there's always space to learn.
Well, terrific comments, everyone, for this scenario, and really appreciate everyone leaning in, especially in the chat and in the conversation. Really enjoy the dialogue, so keep it going. We're going to transition now to scenario number 2, and this is from Denise, and we'll have Denise come offline and go ahead and present her scenario and follow up with the facilitation of questions. Denise.
Okay. Hang in there with me. I have a head cold, so I'm a little stuffy. Okay, so I like this particular scenario because there is so much to learn for our clinicians to know how to treat someone in the LGBT community. There's a lot of fear, assumptions, biases, discomfort that are passed on to these patients, that to the point where they're afraid to get treatment on a regular basis. And so this is a community that we need to get in the room. And when we get them in the room, we don't want to blow it by the way that we completely just trample over their respect as a human being, as I heard earlier. So let's go through this scenario. So we have a Hispanic American male who is a new patient and recently tested for HIV. The doctor has a moral obligation to the same-sex relationship, but he knows he also has a moral obligation to treat all his patients. So during the exam, the doctor's polite but not friendly, and he avoids eye contact, looking at his computer screen most of the time. He decides to skip asking the patient any family or sexual history questions because he makes him uncomfortable, and because he sees the patient has recently been tested for HIV. The patient leaves the health center feeling bad about his visit and wondering if he will ever return. The doctor, meanwhile, feels proud of himself for agreeing to treat the patient despite his sexual orientation and for not saying anything that could be considered offensive and judgmental. And so in this situation, there are key opportunities that could have been applied for cultural humility, and specifically for the provider that goes through the basic exam steps but never extends himself or to connect with the patient. Assumptions are made about the patient's family and sexual history because of his sexual orientation and recent HIV test. The exam is not fully complete as there were areas skipped, and there is a missed opportunity to learn more about Fabian's physical and mental state and the follow-up care or referrals needed. So what is the patient outcome needed today at this appointment?
Monica, I was thinking the same thing.
So, it's funny, but the reality is I was sitting here viscerally thinking about that experience, I would have probably got up and left.
Yeah.
You can't treat what I'm not worthy of you to look at me. I'm not worthy of you to engage with me. I'm not worthy about you to interact with me. And you are supposed to be somebody who's going to help me figure out my care plan. Yeah, no. And you want me to pay you for this? No, not gonna happen. Peace out. Gotta go.
Can I piggyback on what DJ just said?
Yeah.
I once went to an appointment, and it's with the scenario, but I waited in the room for a long time. I saw people chatting at the front desk, everything, and it went on. And I was doing this on a lunch break, and I finally thought to myself, I have a choice here. I don't have to wait. So I got up, I got dressed, and I left. And then, where are you going? I said, I'll reschedule. I've been waiting here 30 minutes.
Yeah, taking the matter in your own hand. I mean, I don't know what this patient walked out thinking, well, what just happened? But what assumptions I may be making about this individual, or what assumptions this person is this doctor is making about this individual. It seems like he treated him like he had leprosy.
Well, and the fact that he has moral objection to the person's sexual orientation, there is the barrier that is preventing the physician from treating the patient. And if you know that you have these biases, that needs to be addressed before you are ever able to even care for a patient.
Yes.
I don't even know how you can be true to who you are as a care provider with this glaring bias out there. You need to address that. I don't even think, just go, take time off work. Yeah.
Right.
Go deal with that before you. And unfortunately, there are so many providers with these biases who they're not even unconscious, okay? They are conscious biases who they hide it from their employers, and then they show up in our workplaces, and then they harm our patients. I was getting ready to put in the chat, the patient needs to report this, and then somebody like me intervenes, and then, there's that.
This particular scenario is a training scenario, and it was the first, you were spot on, all of you around the training. It was the first thing they said, in evaluating this, is that clearly this physician needs to go back and get some major training, and decide whether they are even in the right field.
Yeah.
And there were a lot of different scenarios that I, sifted through and tried to think what would be a really good typical thing, even in the non-binary space, when they're not really sure what the pronoun is, and they do not address the person or ask, what is your pronoun? And will make assumptions from that, and that deteriorates that relationship as well.
Yeah, I would suggest that there are things in place, whether it is some sort of printed material that says, this is our mission, these are our values, this is what we agree to, this is the contract that we enter into with our patients, that X, Y, and Z is going to happen. And then patient, you know, we take this very seriously and we ask you to bring this to our attention if this is something, if the care that you receive is different from what we are committing to. So I would think that it needs to start even ahead of a patient meeting a physician, right? So it's like when you step into our clinic, these are our values that we live and take seriously. And if something else is happening, we need to know about it so that we can course correct somehow.
You know, Heather put a comment in the chat that I thought was so profound, in that in some cultures, obedience and deference to people in power, particularly physicians, is so strong that you will subject yourself to this kind of foolishness. I remember as a 21-year-old single mom with loose family connections, I didn't realize that I could get up and leave. I remember my OB-GYN saying some very abusive things to me. And I didn't have the family support in place. And I sat there under his care for the entire time of my pregnancy and up until the time I delivered my son. And when I think about it today, I literally, y'all, I went back to find him. He has since retired because I had some few choice words for him once I found my voice. Thank God he's retired. But I did not, just, you know, my culture, my upbringing and so forth was like, you listen to the doctor, you do what they tell you to do and so forth. And he was abusive. I remember him saying something to me, something was going on goofy with the insurance. And he said to me, just because you and your mom are too lazy to go figure out what's going on with the insurance, you know, if you've got welfare insurance, then, you know, the state will pay for it and whatever. And my mom had private insurance and I was on her. And I just was like, I mean, he would say things like that to me. And I remember kept going back to him, and he just throughout the pregnancy, he would say stuff like that. And I just was like, my 51-year-old self now, there is no way in the world I would have sat under that nonsense. But again, you know, we pay deference to certain people in you know, these seemingly positions of power. So Antoinette, to your point of getting up and leaving, it never even occurred to me to leave that physician and find another OB-GYN. Because we're conditioned in a way that this is the doctor, their you know, their advice, the instructions and things that they give you, you need to follow it to the letter and so forth. And sometimes it doesn't even occur to you to question, you know, how they're treating you, what they're saying to you, you know, and so forth. And that is a real thing that we have to combat. And unfortunately, there are people who take advantage of that. Not Medicaid, like some days I wish I had Medicaid. Hell, I wouldn't have to pay some of these premiums, but you know, that's an aside. I'm a Medicaid.
Denise, in a situation like this, who else might have been around to observe? Or what might have come out? You say that the examination isn't complete. Is there something that we could do with, might there be anybody else that might have been involved in this that might have advocated for the patients?
You're on mute, Denise.
Oh,
I'm sorry. I was giving you great stuff. I got the impression that the patient, you know, wasn't treated. I mean, there was conversation happening here, but they were not. I think that I just think the upfront diagnosis of being tested positive for HIV changed the perspective of of the care that they were going to get, and And I just didn't feel like that they got, they got the care that they needed, or at least appropriate questions to be asked to make sure that they were, they had everything they needed walking out the door, knowing how to care for themselves or whatever. I don't know if the patient felt comfortable speaking up, just as we were just speaking about earlier around, who's in authority and whether you have that, whether you feel that you can. But when a person is already making you feel like you're not a whole person, you're not certainly going to speak up.
And I also wanted to highlight Dr. Ali. Ali has his hand up and wanted to hear from him as well.
Okay.
And Dr. Ali, you're on mute.
I appreciate this scenario largely because I think it invokes outrage at something that we need to really challenge ourselves a little more than how we are, regarding how common this is, but is how it's not detected. And I think this is a very typical situation for Black patients, because then I end up hearing about it as, the only internal medicine doctor for, KP Washington, who's, African American. So this is very common. This is very, very common. And so we can't treat it like a one-off where it's a bad apple. If you think about system change and quality improvement, you can't think about things as just one-offs. This is a systemic issue, in particular when it comes to anti-Black bias. Most providers have anti-Black bias. The only ones who don't are Black providers. Everyone else has anti-Black bias, and generally more so than not. So it's greater than 50% in studies that look at anti-Black bias in physicians and nurses. Therefore, what are we doing in our own settings? And so I was going to ask Denise, was this one of our internal cases that was reported back, or was it a?
No, it was.
Oh, okay.
No.
Okay, because we have like a reporting system, and I think that helps. But I think even that is just like the very first piece into, stepping, toe into the water.
Mm-hmm.
And so I think what I get out of this is a real challenge to every single one of us on this call who works in a healthcare organization to really ask, where are we missing the boat? Because it's not a question of if this is happening. It's not. It is happening. It is happening. So it's more a question of, where is it happening? Are we even detecting it? Is it only being detected by the few canaries in the mine like myself, who are then coming in later and seeing these patients? And then because there happens to be racial concordance, we hear about that and no one else is hearing about it. So who is in your institution hearing about situations that no one else is hearing about? Are those then kind of captured? So what are the systems in place so that we really can capture this? And if we don't have it, how can we build it? So I appreciate this complexity. Sorry, thank you.
Oh, no, I'm sorry. I appreciate your remarks around that. I think that maybe the patient surveys that we send out need to be more specific, that will get us to the root of what their experience was like. Or give the patient the opportunity to share what their experience was like with that provider on that particular day.
I think we need to set up our patients to have that kind of, to know their voice in the situation. Because I don't think that is taught. Like we don't teach our patients how to be patients, what their rights are, what their expectations should look like, all of those kinds of things. And I will tell you, like, patient satisfaction surveys, as somebody who's had probably more healthcare than I would like to ever have, I hate them and I avoid them at all costs because they feel bureaucratic and like the information is going to be manipulated to somebody's favorable metric of the month. So I would suggest that we try to, one, dismantle the systems that we have in place, to your point, Dr. Thomas, and figure out ways, what are the conduits that we have in our infrastructure to get that information that we're seeking? Because right now, I think we're totally failing at that. And the onus is on our BIPOC providers, which these are people who are already acting with tremendous courage in a space that has not been open to them for a very long time. And so these are kind of like our first responders in that space, if you will. And I don't think it's fair to depend on our BIPOC community and providers to take that lead, although many do. So I think part of it starts with, like, how do we help our patients communicate that information? And I think part of it is helping them know what their voice is.
Monica, I really appreciate that. And I would just further that by saying, we really need to stop and think about the system as a whole. If I were to say the lean to most of us, we would immediately know what that is. We understand it. But lean, the principle of Gemba, says go to the people who do the work. So we talk to the providers. How many times do we talk to the patient, who is really truly the center of the work? We do have focal groups, and organizations are doing that, but we don't build the system around the patient. We built the system around the provider to deliver care. And I get it, I understand it. That's how we've got to work. But because of that, we make assumptions. Because of that, we introduce biases, because we're looking through our lens versus slowing down to stop and look through the lens of the individual in the room. Because I guarantee you, all of us can name a time where we felt like we didn't get the best care we needed. We felt neglected. We felt maybe a little mistreated. We felt a little bit, and we just accepted it. That's just the way it is. It's the system, it's this. But maybe that's slowing down and doing some work with our patients to make sure that they understand and that they are a true partner in the process, not just something that someone that this is happening to. Might be a great place for us to start this work and to deepen this work as we continue to move forward.
Yeah, DJ3, I'm jumping to solutions here based on what you're saying and a comment that Julie made. Nurses are, we just had Nurses Week and whatever, and not to minimize that. Please don't come at me. But our nurses are some of the most trusted people in healthcare. And if we can, not that they need more work, but make them part of the conversation with our patients and circling through that. Like, how can we do that to get the right information? Because people will talk to nurses. They may not talk to physicians or providers because they are, the learned people and sometimes come with the power and all of those things. So I think nurses are a good opportunity.
Interesting. Healthcare. I've worked in a number of industries, and for whatever reason, because we have, it's so interesting, this paradigm in healthcare. So I've worked in consumer product goods, I've worked in retail, I've worked in IT, gosh, you name it. And every industry that I've worked in, with the exception of healthcare, the organization and the industry does an excruciating amount of research and work around knowing their customers and knowing the specific, like big data. Think about what big data does. It knows every single thing. I mean, you get in the mail coupons that is based on the fact that you bought green beans the week before. And so they know your habits to that level of degree. Yet the very thing that we do in healthcare is caring for people. And we've built a system that has not taken into account the very people that we're there to take care of. which is just astonishing to me. And so when you use the word consumerism in healthcare, all the physicians lay on the floor and they die. They're like, oh my God, I cannot even believe that you're introducing something as, it's almost like heresy that you're even talking about consumerism and the fact that your patient is a consumer. They are a consumer of a service that you are providing to them. And just like P&G, Procter & Gamble knows what type of diaper your baby wears, what type, of formula, what type of, they know every single thing about you. We don't do the same thing in healthcare in terms of learning every single solitary detail about our patient and subsequently design a system that is that is geared towards catering to the needs of our patient. Yet you go to Home Depot, but this time of year, what is it, spring? They've got weed and feed sitting out. They've got pansies or whatever the heck those flowers are or whatever sitting out. They know you're gonna need flower pots and whatever. They've done extensive research to know exactly what to put in front of you. So you walk in that store, you're coming out with $200 worth of stuff when you went in to buy, garbage bags or whatever. And yet in healthcare, we don't do the same thing. We know nothing about our patients. We don't even try to learn. We walk in the room and we look at the clipboard and like, okay, I see you have heart disease and, you need a specialist and, on your way, and this is the person I'm going to refer you to. And, 15 minutes, you're in and out of the door. You go to Home Depot, they're following you down the hallways, the aisleways, and they're telling you, you need weed and feed, and you need this, and this, and that. And I don't understand why in an industry that is geared towards taking care of human beings, we don't take the time to learn who our consumers are. It's not a bad word. They are there to consume the service that we're providing to them. And it is incumbent upon us to know everything that there is to know about them, including their culture, history, background, preferences, and so forth and so on. And if we could only switch that and not necessarily lose the person in all of that, I think we would be just as successful as you see, these companies, these T-Mobiles of the world and the Amazons of the world, because they know their customers. We need to do the same thing for our customers. And we need to teach those folks who are going into the business of caring for human beings, how do you learn more about a human being? How do you use an iterative process to understand more about this patient that's going to come in front of you? How do you exercise cultural humility, which is a lifelong learning process to know more about people who are going to come in front of you? And oh, by the way, this population is going to get more and more diverse. Their needs are going to be more and more diverse. And I think if we could apply those principles, I think we'll be more successful as healthcare providers. Yeah, I know, DJ3. Yeah, you get a text. You walk in the door because through geofencing, they can tell exactly where you are and what you're doing at any given time, and they'll send you a coupon. You're like, I didn't even come in here to buy a bug spray, but while I'm here, I got a coupon for it, so let me go ahead and purchase it. Huh. I got 20% off for an EKG. I don't know, maybe I might run it. So.
That was a good discussion. I don't have any additional things to add.
All right, lots of really good points. Wow. So we're coming at it at so many different angles. That's what's really appreciative right now. We're not only coming at it from different angles, we're comparing it to shopping at Lowe's and Home Depot, which you're exactly right. 25% off of medical care. That might, that sounds pretty snazzy. As we're talking about this, we can kind of see culturally how this occurs, and we can see it in different pockets, right? We can see it. The thing that kind of kept coming to mind as we were speaking was the Olympics that just occurred, right? And when we think about the Olympics and the physician that was kind of being invasive and inappropriate with young gymnasts, with female gymnasts, just in that aspect, I mean, we can see how some of our most celebrated athletes, the ones that we look up to and we admire so much, for their performance, yet they're there and they're still being, they're being treated as less than and kind of taken advantage of by a physician. And just, you know, it's just interesting to see people who are so out there and bright and excelling, and yet they're being taken advantage of in different scenarios because of that trust factor that I want to say that I learned from my mother and I learned from my father, right? How, you know, don't talk back to the doctor, they're always right. And so we see that in different generations as we keep coming up. So lots of different pockets of cultures. Where else do we see these kinds of things happen? We see it, you know, we're talking about the healthcare system, and here in hospitals, we can see that happening to athletes and professional athletes that are being victimized. Where else do we see this happening? How else do we learn this culture, and how do we turn it around?
You know, so at its core, we have to deal with the realities of power. We have to be just bluntly honest about the realities of power. We pretend like, oh, there's not a power dynamic, and there's not a power structure, and there's not a this, or there's not a that. But the reality is, in our society, if you went to school, you went to school. And it's interesting, we practice medicine. You know, and most physicians will tell you this is the plan, this is the approach, but there's always that possibility that we're not on track. So it's one of those things that we have to understand, that power does not always mean right. Power does not always mean appropriate. Power doesn't mean, we've got to get to a place where we respect and honor everyone in whatever role that they show up in. So whether I'm a physician, a nurse, the front desk, the MA, the phlebotomist, the billing person, wherever I am in the process, if I'm honored for what I bring to the table, and then seen as being a valuable contributor to include the patient, I think we create a system where we get better outcomes. But until we're willing to speak truth to power, we're going to continue to just perpetuate this exact same thing.
I like your inclusion of all of the providers that might be involved in the care DJ3, because one of the things that we've been looking at is handoffs, and trying to create within just our own little campus is, you know, they go for, you know, I'm the care provider, and okay, off you go to the lab for your blood draw, then off to the pharmacy to pick this up. Oh, and then come back and sit and wait another 30 minutes and we'll talk. And then what are the individual interactions, and how does each individual provider, you know, what happens on that patient journey? Are all the providers providing that cultural awareness that keeps the whole interaction positive? So it's not just the one-on-one, it's the whole journey through a clinic.
Lots of good information and points. We're going to be coming to a close, so I'm going to extend an offer to everyone. If you had something in the back of your mind you wanted to say, now's a good time to share it. We do have a few more minutes to hear a few more people with their perspectives or input and information. So if you had something you want to say to this group, now would be a perfect time. Floor is open.
Could Joe speak to the community organizing point?
Yeah, I was listening to everybody's thoughts about power and the need to, you know, change systems. And one of the projects I used to work on as an organizer was going to community health centers and then kind of talking to the patients one-on-one. I mean, I think that kind of answers, or would be my answer to the question of building trusting relationships where you have a one-on-one discussion and kind of understand each other's self-interest. And if there's a mutually shared self-interest, then there is something to kind of work off of. And then from there, we would think about, you know, what are the issues that are really relevant to your life, whether that be, in this case, cultural discrimination, or could be like a lack of affordable housing or a lack of a job. And then from there, we would try to kind of provide tools on like how community organizing works. So then the patients themselves would be the ones that are wanting to advocate. And if they desire and need more support from physicians and nurses to kind of march with them in the streets or, you know, bring their issues to management, they'll be there to kind of do that, because obviously the white coat is very powerful. So I think, I don't have the answer, but I thought that was a very innovative way to kind of address some of these systemic issues.
Thank you, Joe. Great comments on that. Any other comments or feedback? All right, hearing none, we're gonna go ahead and get to the end of this session. We wanna thank everyone, and we have DJ3 who's gonna close us out. DJ3, the floor is yours.
Thank you, James. And to everyone in the room, give yourselves a hand. Yes. This right here, this experience that you had today, this is the value of HILT. Us being able to have a space where we can come together, have tough conversations that stretch us, that challenge us, that move us from where we were to another place, is exactly why HILT exists. So thank you so very much for coming. And if you ever wanted to go back to your leadership and say, hey, I'd like to bring more people into the HILT experience, I'd like to share, here's the reason, here's the proof, here's what you go back and tell them. We are making a difference. Great conversation. I want to encourage you to not let it end here. So as you are having these experiences and you are developing learning and you are doing things, bring that information back. Share them with us. We're going to be creating a library where we'll be including these scenarios. We'll be continuing to do this sort of work. So we would really encourage you to continue the work, continue the conversation, and not let it just die. Don't just walk away from this encounter today, but go back. And someone put it in the chat about what could we do? And the reality is this. It starts sometimes with just one person being willing to say, yeah, I don't get it. Help me understand it. I need clarity, or simply saying, no, that is not right. And we as an organization can no longer endorse that or be a part of that. So when we think about those next steps, the next steps is continue to think about it. Continue to have conversations about it. Continue to explore. Be uncomfortable with being uncomfortable. And if you need to have a conversation, there are, 15, 20, 27 of us who you can reach out to and have that conversation with, because you're not alone. I would also encourage you, go back to your leadership, go back to your peers, tell them there's a tremendous opportunity to get involved in what we're doing here at HILT. Our next big opportunity to get together will be our spring quarterly meeting. It'll be May 26th, 9 to 11 a.m. If you haven't got the information, reach out to James. He'll make sure that you get it. Reach out to one of the co-captains. They'll make sure you'll get it. We'll be doing best practice blitz. We'll be talking about networking. We're going to be hearing the latest from inside of healthcare organizations on training. And maybe you haven't figured out, if you haven't, DJ3 is not a big fan of the word training. I realize we need to do it from time to time, but I'm a huge proponent of learning. Training kind of speaks to a one-off activity. Learning is a lifelong experience. And I think we should always be moving forward, always learning. We'll be talking about employee advancement and talent management. So again, want to thank you for your time. Want to thank you for your contributions. Want to thank you for your sharing. You rock. I salute you. I compliment you. I give you the hands up. Have a tremendously fabulous day. And thank you so very much, everyone.
Thank you, everyone. Bye.